Hey everybody, we've got the first episode from the new season of the Pitt, and I'm super excited to see this for the first time. Let's watch it, react to it, and break down some of the scenes in it. So let's dive in.
Morning, John.
Could have sworn it was still around 4 a.m.
Did you guys have an easy night last night? The waiting room actually looks manageable.
I wouldn't call it easy, but not too bad. I figured we'd have hands and burns down here a bunch, but so far nobody's blown off any fingers.
Oh, you just jinxed it.
Oh great, yeah, we're really superstitious. Most of us are. You don't jinx things. You don't say what's gonna happen. You never say the Q word. Quiet. It's a quiet shift. It's a quiet night. It's really quiet in here. You never say that. And whoever says that, they're gonna get railed on. Yeah, you'd be really surprised. We don't use the number 13. You'll notice there won't be any cubicles number 13. There won't be any rooms number 13. Not everybody's like that, but most of us are. And I'm guilty as charged.
The results came back normal, Mrs. Walker.
I'm dying.
You're not dying, Mrs. Walker, I promise.
Jesus is coming for me.
If he is, he hasn't checked in that registration yet.
Please.
Hey, Margaret, we're gonna have the hospital chaplain come and see you in a moment.
I'm not gonna last that long.
Yes, you will, because we're going to give you a shot to keep you alive until they get here. What are you thinking, Dr. Abinovich? 500 mics of cyanocobalamin?
At her condition, I'd push a full 1,000.
Whew. Are you hurt?
Oh, great. They're going to give her a placebo. Come on. I think that goes against quite a few rules. But funny that they should mention, I'll give you an injection to keep you alive. I literally have injections that keep people alive in certain situations. And usually when I'm called down to the ER, it's for critical care and they need life support or advanced life support. The person is dying and they think might need to come up to intensive care. And sometimes we don't have enough information about this patient. So John Doe off the street, or we don't have enough records. And usually their blood pressure is crashing and they're, I've got 2 syringes in my pocket that I usually carry around with me. And I'll bring them up on the screen. So one is called metaraminol and the other is the adrenaline syringe. So I can give that patient a little shot of either. So the metaraminol is what we call a vasopressor. It'll squeeze the blood vessels and raise the blood pressure artificially so we can keep that patient alive. And the adrenaline, that's what you think it is. It's adrenaline. It's the adrenaline that we normally use in a cardiac arrest. You push the whole syringe to restart the heart. But in our situation, I'll use a little sort of 1 cc or half a cc just to keep the heart going a little longer.
And so it begins.
So it begins, in the words of King Theoden. Was it Theoden? I think so. And we always say that, so it begins. Always put in that Lord of the Rings reference somewhere.
See a doctor. Our new attending is torturing our intern and med students in Trauma 1.
Tell me about this new attending.
She's pretty, divorced, 1 kid. Can already tell she is a strict rule follower.
Great.
What's her name again?
Dr. Baran Al-Hashimi.
Al-Hashimi? What is that?
Irish?
Bran Al-Hashimi. If it was O-Hashimi, okay. But no, it doesn't sound Irish.
Some sort of clinical informatics expert. When she started talking about AI, I started thinking about robots and kind of stopped listening.
Ooh, yes, that's a kind of sensitive topic nowadays. AI and the whole thing. And there's a lot of pushback from medical professionals about AI. But one thing I gotta mention, this is not true AI. This is not general AI that we're talking about. And after ChatGPT and everybody coming up with their own diagnoses, etc., it is making life a bit more complicated for us. But AI has really, really great applications in medicine, and there's one application I'll just mention in brief. It's a piece of AI software that listens in when you're consulting a patient, and this has been used in primary care. So it'll listen in on your conversation when you're having with the patient, and as soon as it picks up certain phrases, certain things, certain sentences that you say, it'll automatically write referrals, write letters to other specialties. If you're thinking of doing a referral, it'll order investigations, all while you're just talking with the patient. It'll do all these things automatically. Most of the time is taken up after you've talked to the patient, typing up letters. Your patient needs a cardiology consult. You'll have to type a letter to the cardiologist. Now this AI will have done that already automatically. It would have ordered the relevant investigations, EKG, echo, all those orders will be sent in. That's all the sort of the admin paperwork side of things, which takes up so much time. Even with computers, even when it's online, it just takes up time, and this AI tool will actually do all that for you. But anyway, we'll see. Maybe she's got different ideas. This new Irish attending.
Clear. Off the chest, Ogilvy. Get ready to step up here, Joy. Ogilvy, off the chest. Clear.
Still VTAC, but it looks weird.
Agreed.
Okay, so they're in a cardiac arrest. It feels a bit relaxed. I'm thinking this is a drill early in the morning. Yes, so it looks like VTAC. Doesn't look like your classic VTAC. It looks what we call a polymorphic ventricular tachycardia. But anyway, we'll see.
We haven't considered all the T's.
I checked for tamponade and tension pneumo.
Well, what if it's thrombosis? If it's a pulmonary or a cardiac clot, TNK could save it.
We are sticking with the algorithm for now.
Oh, great. So he mentioned the algorithm. That's the almighty algorithm. No, it's not the YouTube algorithm. He's talking about the advanced life support algorithm, or the advanced cardiac life support algorithm. So that's the algorithm we use to resuscitate a patient while they're in cardiac arrest. CPR is not just jumping on the patient's chest and doing chest compressions and praying that the heart comes back to life. There are certain things that you have to do in order to bring the person back to life. The algorithm, or the protocol, it's broadly divided into two depending on the type of cardiac rhythm. So cardiac arrest has a rhythm to it on the EKG. There are two types of rhythms that you will treat differently. You wonder, they'll give them a shock to jumpstart the heart. No, not every cardiac arrest needs a shock. There's shockable rhythms, which is the VTAC, and the ventricular fibrillation. Those are the two rhythms that you're going to have to shock at certain points. The rhythms that you don't shock are the asystole or the flatline. And I know in lots of TV shows in the past, they'll show a flatline. Oh, it's flatlining, shock them. No, you don't shock them. The other rhythm is a pulseless electrical activity. That means you'll see an organized rhythm on your EKG, but there is still no pulse. There's no effective pumping of the heart. So those are not treated with shocks. You'll have to give adrenaline. And then they were talking about the T's. So what are the T's? So you actually have the 4 H's and the 4 T's. For resuscitation, what we do is, while you're doing chest compressions, you have to find out what's caused this cardiac arrest. Why did his heart stop? And if we can find out what caused his heart to stop, we can try and reverse that. So we're looking for reversible causes of cardiac arrest, and that's what she was mentioning about the T's. So there's 4 H's and 4 T's. I know it sounds like a lot, and that is why these drills happen. Go through the 4 H's, 4 T's systematically.
Please.
You need a break, Joy?
No, I need an attending.
I'm right here. Stop compressions, we're calling it. Sorry, the patient's dead.
Yes, the patient is dead. He wasn't alive to begin in the first place. So that's pretty cool. So we have a dummy like that, which has all the sort of the relevant bits and bobs. And you see even the chest compressions, you've got a dummy that'll tell you if you've got adequate depth, and of course adequate recoil as well. That dummy will tell you if you're doing proper chest compressions.
John Doe, dishwasher, penetrating trauma from a kitchen knife to the right chest.
Assault or accident?
Unclear. Initially had a pulse, lost it 2 blocks away.
Penetrating trauma to the chest from a dishwasher. Okay. And he's in cardiac arrest. We're going to go into the 4 H's, 4 T's. I think we kind of know what this is. It's going to be most probably H and possibly T as well. Tamponade or maybe a pneumothorax, but definitely a hypovolemia as well. So you can have a combination of different things causing the cardiac arrest as well. So it's not going to be just one H or one T. It could be multiple H's, multiple T's as well.
3. Prep for a left thoracotomy. I'm on it.
So it's a penetrating trauma, but the penetrating object's still in there, I'm not sure. But what they're going to do is they're going to do a thoracotomy. They're going to cut through sort of underneath the ribs, spread them out so they can get a good view of what's going on inside. It's going to be pretty gnarly. I've seen a couple of these myself, but it's been a long time.
Chest tube to the right. Stand by with massive transfusion protocol.
I put 2 units on the infuser.
Stare with left 6 in it.
They think he's got a big hemothorax, so they're going to put chest tubes to drain that blood out, because you don't want blood collecting around the lungs, around the heart. So they'll open up the left side, put a drain on the right side. Sounds.
Giovanni, you're on section. Whitaker, get ready for internal compressions.
So they're going to do internal compressions. So they're doing external chest compressions at the moment. They're going to open his chest up, and they're actually going to squeeze the heart while it's inside with your sort of gloved hands. Again, pretty gnarly. I've done it a couple of times on when I was working in cardiothoracics. Basically, patients who were post-op went into cardiac arrest, and the best way to do chest compressions is to release the sternotomy wires, open the chest up, and massage the heart. It's pretty clean for a penetrating trauma. There's going to be way more blood than I guess they can show on screen. Ooh. So I'm going to have to blur most of the stuff out, but yeah, so they checked for tamponade, one of the T's, and it says pretty dry in there.
Heart's empty. Somebody start cardiac massage. I'll cross clamp.
Yeah, I got it. You do these one-handed, pushing up against the breastbone, 4 fingers.
Very good. No.
It is very clean for a major chest trauma. I mean, I guess they got really good suction that's sucking all the blood out.
Let's keep transfusing. Open the right chest.
That is correct. Booty's on, kids. There will be blood.
There will be blood. I love it. First it was Lord of the Rings, now There Will Be Blood from There Will Be Blood.
Try to identify the source,
Could be the right ventricle.
or more likely the hilum.
Fresh lap pads.
They're trying to figure out where the bleeding's from, and the new attending thinks it's from the right ventricle, but I think they already examined the heart, and they couldn't see any bleeding from there. Robbie thinks it's the hilum of the lung, or the root of the lung, where you have the bronchi, sort of your air passage that goes through there, and sort of the pulmonary vessels as well.
You need better exposure.
Convert to a clamshell.
Exactly.
Trauma shears.
So essentially they're gonna open the chest up a bit more, what's called a clamshell. Yeah, I'm gonna have to blur a lot of this out. But if it looks really real, except there's not much blood. I would expect more blood. But then of course you won't see anything. The camera won't see anything.
Ventricle looks good. Massive hemorrhage from the hilum.
So that's what we're talking about. The hilum of the lung contains the bronchus, the air passage, and the blood vessels. So they've identified the bleeding as coming from one of those blood vessels, either the pulmonary artery or the pulmonary vein.
Clamps on.
Hilar flip. You're gonna rotate the lung 180 degrees.
Ooh, hilar flip. Actually, they're going to rotate the lung, sort of to twist the blood vessels, cause a kink, stop them from bleeding. Okay. Oh, that's gonna be a new one actually. I like the show. They're showing all sort of the extremes that you could go through to treat it. I think there'll be simpler ways, sort of to clamp, etc. Okay, we'll have a look. Hilar flip sounds exciting.
Or he'll die when you rip the entire lung off the hilum.
True.
Gently. Very, very gently, very, very slowly.
Oh, it's not going to be that easy, I'm pretty sure.
The heart feels empty.
Okay, we fixed the leak. Now let's fill the tank.
All right, it worked.
As we started.
Hold compression.
Nice. Oh, nice. That's very CGI. I don't know if I can show that. So the heart was sort of fibrillating. That's the word I can use. So it's in ventricular fibrillation. It's in cardiac arrest. And it's a shockable rhythm. They don't have the rhythm on the EKG, but you can actually see the heart fibrillating. So they're going to shock it. But how are they going to shock it?
Resume compressions.
When the heart quivers like that, it's obvious P-fib.
Okay, internal paddles ready?
Charge.
There you go.
25
50
joules.
joules.
So do you see that? Those are internal paddles. So the shocks that you give on the outside are external defibrillators, and you can have either sort of the stickers that go on, or you have the classic sort of handheld paddles that you use. What you saw there were those big sort of spoons, as it looks like, are internal paddles, and they've got sort of little round metal discs on them, and you would make contact with the heart directly with those. And you heard 50 joules. That's the amount of energy that you're going to give to the shock, and you'll notice it's far lower than the energy that we use, if you're paying attention, than that we use in a external defibrillator. That's because it doesn't have to go through all the chest. Basically, it's directly to the heart, so you use a lower energy. But that's really good. I'm surprised they're giving Whitaker this much responsibility.
Charge.
Okay, Whitaker, when you're ready.
Clear.
And
That's
there
what
you go.
normal sinus looks like.
Normal sinus.
Strong carotid. Saline lap pads and up to the OR.
Oh, nice. So you'd think this was pretty realistic, and actually it was. Most of the physiology and the medicine was real, but the situation would have been much more chaotic. They wouldn't just walk away, daddy. He would not be that stable. He would need so many more things. He's just had a proper cardiac arrest. He's got an open thoracotomy. It's not going to be this calm. It's not going to be this collected. People, will be running around, and there'll be so much more blood. When Robbie says there will be blood, there should have been more blood.
We're about to get the morning rush.
What do you mean?
Every morning around this time, the nursing homes and assisted living facilities do their morning bed checks.
This is, I think this is a universal issue. Because they're in the ER, they're going to talk about the care homes, the assisted living places, and they're going to do their observations. They're going to check on their patients, and they'll find some of them are not as well as they appear.
It looks pretty quiet to me.
He said it. He said the Q word. He said the Q word, quiet. You never say that. You'd never say that. Oh, this is so accurate. The looks.
Incoming!
Oh, like
There
I
you
said.
go.
Come on.
Ethan Bostic, 79. Found altered this morning at assisted living. No history of dementia. Has a pulse. What's a pulse?
Physician orders for life-sustaining treatment. No CPR, no intubation.
Oh, great. So this is what we're talking about, the ceilings of care that we set on. So this is an old gentleman who's got dementia, is living in an assisted living or care home. CPR would not be appropriate in his circumstances, because you would not probably get him back from a cardiac arrest, and even then his quality of life will be so poor. It's already deemed that he shouldn't have chest compressions. So he'll have life-sustaining treatment. That means he will have fluids, antibiotics if he's got an infection, and things like that, but not advanced life support. He will not, I don't think he'll be intubated or put on a breathing machine. He will not have vasopressors, or maybe limited vasopressors to keep his blood pressure up. So these are really important things, and it's really good when they come in with an advanced order like this. Sometimes, most of the time, we get patients who don't have any sort of advanced directives or advanced plans of care, and then it's really difficult, and that's when I use my 2 life-sustaining syringes to keep them alive until we can get enough information. And sometimes we even have to ask the patients themselves, if they're compos mentis, what their wishes are, so we can incorporate that. And so it can be complicated, but this gentleman's come in with all that sorted out, and that is really great. That means they most probably won't call us. Thank you very much, emergency department.
There's nothing for us to do.
South 15 is open. Well, do not resuscitate does not mean do not treat. He may perk up with fluids, IV antibiotics.
노인들을 괴롭히는 거 누구나 다 좋아하지.
Exactly. Torturing the elderly. This is something people don't understand. Medical treatment, it's not a walk in the park. It's not magic bullets. It's not waving a magic wand and they get better immediately. Some of the procedures that we do are horribly invasive. Even just putting a drip, putting a cannula in can be painful. Putting central lines and things are very distressing, and those are needed for advanced life support. Putting a patient off to sleep on a breathing machine, on a ventilator, it's akin to torture sometimes. So that's why it's not appropriate. And sometimes patients who know this, who have an idea about this, will have directives saying, if I'm unconscious, don't do this to me, don't jump on my chest. And that's why she mentioned it's torturing the elderly. People get old, people will pass away eventually. We don't want to be doing unnecessary things.
VTAC, can I?
Yeah.
No pulse. Should we call for a code blue?
No CPR. No shock. We honor his pulse and his wishes.
So what does that leave us?
Making sure he's comfortable.
I'll suction.
Altered mental in the elderly can also be toxicity from anticholinergics, sedative hypnotics, opioids. Am I missing something?
Social skills?
You and him both. Hey, that was great. Just hit the ground running with that one. We're going to be keeping a close eye on the pit. I'm sorry if this has taken some time to come out. As you see, I was working, and I don't know if I have time to edit this, but hopefully this will come out in time for before the second episode at least. And great. If you got any comments, please let me know. Leave a subscribe if you like this sort of content. If you want things explained more simply, I'll try to be a bit more simple, but I just love this this show, and I'm looking forward to the next episode. So everybody, stay healthy, stay safe. I'll catch you in the next one.